Everyone. First of all, let me thank Dr. Sandeep for giving me this opportunity. I'll be talking on perioperative pressure changes during phaco emulsification. So the perioperative period is pre-op period, the intra-op period, and post-operative period. So what about the preoperative period? Topical anesthesia is IOP neutral, whereas peribulbar anesthesia can raise the pressure by about 10 millimeters of mercury. If you're concerned about that, you can reduce that with the help of a ball compression. You can bring it down back to the pre-mean IOP. Be mindful about the pupil dilation in angle closure disease, especially if you have not done a laser PI. Intraoperatively, we know for some time now that the pressure increases during phacoemulsification to about 60 millimeters of mercury. There could be transient intraocular pressure up to 100 millimeters of mercury during some of the steps, like viscofill of the anterior chamber, hydrodissection, and IOL implantation. The risk of optic atrophy is possible in compromised optic disc. The IOP depends on the fluidics parameters, bottle height, aspiration flow rate, fluid escaping through wounds, nucleotomy techniques, and vacuum settings. The higher vacuum develops during occlusion, and for better anterior chamber stability, we increase the bottle height, and this will increase the intraocular pressure. And when there is a sudden eating up of the nucleus and there is a loss of chamber pressure, there is a big fluctuation that can happen intraoperatively. This higher AFR needs higher bottle height. So what is the problem with higher bottle height? You have high IOP. This compromises the blood supply to the retina and optic nerve head, and adverse effects are on vulnerable optic nerve heads. There is also higher endothelial loss and greater postoperative inflammation. This study by Vaishali Vasavada, they looked at two parameters, a low parameter and a high parameter. In the low parameter, the AFR was kept at 20 and bottle height was 70 for sculpting and chopping, whereas for fragment removal, it was 90. And for higher parameters, they kept the bottle AFR at 40 and bottle height at 90 for sculpting and chopping and 110 for fragment removal. What they found was that maximum intraocular pressure was 86 millimeters of mercury when the AFR was 40 and bottle height was 110. And these peak IOPs happened in foot pedal 1 and when there was an occlusion of the tip. Intraoperatively, what they found was that the surgical time, the fluid used, and the cumulative dissipated energy was higher in the low parameter group, but in the low parameter group, there was lower fluctuations in the intraocular pressure. This in turn resulted in clear corneas postoperative day 1 and decreased anterior segment inflammation. This study looked at the early postoperative intraocular pressure after cataract surgery. So the mean IOP was 15 to start with. In the early post-op hours, after 4 to 6 hours, it increased to 24 millimeters of mercury, which started coming down with time. By 24 hours, it was back down to 18.3 millimeters, and by day 7, it was 16 millimeters of mercury. So this is a patient who was 60 years of age, who was POAG with 18 pressures, on 2 anti-glaucoma medications with stable visual fields and visually significant cataract. What next? Do you do phaco alone or a phaco trab? So cataract surgery can be an effective mix. It is minimally invasive, small corneal incision, excellent safety profile, proven sustained IOP lowering, and all options remain for future intervention. So what are the signs of lowering after cataract extraction? In open angles, there could be remodulation of the extratrabecular matrix because of raised expression of interleukins 1. In narrow angles, the level of IOP lowering is proportional to the angle widening. So anterior vaulting may be a predictive factor. This is not very effective in PACGs where there is an extensive peripheral anterior synecdoche. When we compared phacoemulsification versus phacotrab in narrow angle glaucomas, we found that both did produce a lowering of intraocular pressure, but phacotrab had a better edge. And there was a more drop in number of medication used also with phacotrab. Reduction in intraocular pressure after cataract extraction in ocular hypertension treatment study. So there was a sub-study which looked at the cataract extraction in ocular hypertensive patients. They found that at 36 months, about mean pressure of lowering of 4 millimeters was possible after cataract surgery. Another interesting data is that about 40% of the patients had more than 20% decrease in, more than 40% of the population had decrease in intraocular pressure of more than 20%. Intraocular pressure increased only in 10% of population. That was, it was marginal. Coming to long-term effects of phacoemulsification on normal-intensive and ocular hypertensive eyes, the interesting thing is, as the mean IOP preoperatively was higher, they had a higher change in intraocular pressure. So you can see that the first group had 6.7 millimeter change, whereas when the pressures were in the normal range or in the mid-teens, there was not much of a change. So things to consider, patients with a lower pre-op intraocular pressure may have higher IOP after Phaco. And the pre-op IOP was between 15 and 17, 55% of them had lower IOP, 30% had higher IOP, and 15% had no change. If IOP was less than 50 millimeters to start with, 55% of patients had higher IOP. Post-trabeculectomy patients, IOP may increase by about 2 millimeters on an average, and 30 to 50% of patients may require additional anti-glaucoma medications. To conclude, phacoemulsification alone reduces intraocular pressure, and reduction in anti-glaucoma medication is possible. Thank you.
So there, do we have?
Of understanding this pressure changes.
Yeah. Do we have a question? I mean, time for a question? Yeah. So Manoj, I think I don't remember the study. There was something in the long term which says that the pressure comes down by 1 millimeter if you do cataract surgery.
Yeah, that depends on the initial pressure, sir, the population they have studied on. So in this particular study that I showed, there were patients who were hypertensive and normotensive. So the normotensive patients don't have that much of a response, and the pressure reduction lasts only for about a year or two. After that, it comes down to into the mean. Whereas the start off with the pressures were higher, there you can expect more dramatic reduction of the pressure.
So this is from a glaucoma consultant perspective. As far as cataract people are concerned, what is the importance is this, if you're operating under low phaco parameters, so the shatter of the pieces will be less and the corneal clarity will be more. And more importantly, in certain special situations like IFIS or posterior polar cataract or in high myopes where the scleral rigidity is low, you will have to enter the phaco probe with low infusion pressure because you want a stable chamber, low infusion pressure. So proportionately, you will have to reduce the vacuum and aspiration rate so that there is no sudden shallowing or collapse of the anterior chamber. So in those situations, the chamber will be stable. So you will be able to do the phaco safely. Thank you, Dr. Manoj, for that.